Great. So I think we'll go ahead and get started. Hello and welcome to the webinar, Improving Hygiene in Liberia with Storytelling and Interactive Voice Response Technology. My name is Tyler Best, and I'm a Senior Program Officer at the Johns Hopkins Center for Communication Programs, where I support the fantastic Breakthrough Action Liberia team. Next slide. So we have three presenters that will be sharing with us today. First, we'll hear a bit about the Hygiene for Health campaign from Amos Gborie from the National Public Health Institute of Liberia. Following that, Lindsey Leslie will share with us how Breakthrough Action has used a storytelling campaign to change hygiene-related behaviors. And finally, Nii Lante will share important lessons from the platform that this campaign used, called Interactive Voice Response, or IVR. And after that, we'll have some time to hear more from the presenters during a Q&A session. Next slide. Speaking of Q&A, please submit any questions that you have throughout the session into the Q&A function on the bottom of your screen. We'll take note of those questions and save them for the end. Also, feel free to introduce yourself within the chat function. Next slide. Now let's get on to the show. For our first presentation, Amos Gborie joins us from the National Public Health Institute of Liberia, or NPHIL, where he's currently serving as the Director of the Division of Environmental and Occupational Health. Amos has vast experience working within the Ministry of Health and is also an adjunct lecturer at the University of Liberia. Over to you, Amos.
Good morning, everyone. It's a pleasure to join you on this webinar to share some experiences from Liberia. Next slide. I will begin with hygiene. What do we consider hygiene in our hygiene promotion interventions in Liberia? So according to the Joint Monitoring Program, the UNICEF and WHO, hygiene is the conditions and practices that help maintain, help and prevent spread of diseases, including hand washing, food hygiene, and menstrual hygiene management. So this is the core of our hygiene for health campaign strategy. And as we proceed in our subsequent slides, you get to know about the strategy. Next slide. So in Liberia, I'll give you a snapshot of what the hygiene status looks like. There are about 84% of Liberian households that access drinking water from improved sources. 47% of Liberian households have improved toilet facilities. That tells you that about 53% of them don't have access to improved toilet facilities. In terms of hand washing, there was a 2019 Liberia Demographic Health Survey conducted, and that survey found out that in terms of hand washing places, 20% of those people who were surveyed, 29% have available water, and 23% of them had soap. So it tells you that there's a huge gap in terms of infrastructure for hand washing. There are several hygiene-related policies in Liberia, ranging from the Water Supply and Sanitation Policy of 2009, Raw Wash Compact of 2011, the Water Sanitation Hygiene Sector Strategic Plan of 2012 to 2017. However, these strategies or policies exist, but there are gaps around funding. So funding is a major challenge on how do we scale up these interventions. That's how we were able to come up with this campaign, Hygiene for Health campaign strategy. Next slide. There are several agencies. Hygiene in Liberia, hygiene services or hygiene promotion services are fragmented to some extent. There are several agencies of government that are involved with water sanitation and hygiene, beginning with the Water Sanitation Hygiene Commission. The WASH Commission coordinates overall wash services. The National Public Health Institute of Liberia and the Ministry of Health lead on hygiene promotion. The Ministry of Education plays a role in relation to school health. They focus mainly on wash in school. The Ministry of Public Works, particularly the Bureau of Services, is responsible for rural water sanitation and hygiene services, focusing on rural water point, provision of rural water point and sanitation facilities. The Liberia Water and Sewer Corporation is responsible for urban wash services. Next slide. So hygiene for health strategy. In 2022, we met as a government and said, we need to develop a strategy that will guide hygiene services in Liberia. So that strategy was launched in June of 2022. It's a government-led effort spearheaded by the institute where I serve as the director of the program. The strategy encourages collaboration across sectors. As you can see, there are several actors in the WASH landscape in Liberia. However, they are implementing partners that are supporting government efforts. We have partners such as USAID, Breakthrough Action, Water Aid, Action Against Hunger, World Hope, UNICEF Liberia. But the government institutions that are also supporting the Ministry of Health and MPHO who are leading this effort, we have the Ministry of Education, the WASH Commission, and the Ministry of Public Works. Next slide. The campaign has a focus, and that is around accelerating progress towards equitable and inclusive access to good hygiene services in Liberia, focusing on several settings. So in my subsequent slide, you see the settings, mainly looking at provision of quality, dignified and gender-responsive wash in schools and healthcare facilities as key enablers for improved health outcomes. Next slide. The objectives are clear. We have 5 main objectives. Objective number 1, promotes and sustain hand hygiene practices at all levels. To scale up personal hygiene, menstrual and oral at all levels. To influence behavioral change through increased awareness to end open defecation and improper solid disposal of waste. To promote safe food handling at the household and commercial levels. We look at institutions such as schools, hospitals, restaurants, hotels. And lastly, to promote the use of safe drinking water at the household level through the proper collection, storage, and treatment. Next slide. There are a number of essential behaviors that the campaign is focused on. You can see mainly around unhygienic household water storage. The issue of water safety is a major problem in Liberia. So we are focused mainly on how we can make the water that is consumed at the household level hygienic. There's limited practice of water treatment, gaps in hand hygiene, oral hygiene is a major problem, especially among school-going kids. There's poor food hygiene and feeding practices mainly among breastfeeding mothers, poor menstrual hygiene management among girls of school-going age, but also those that are also out of school. Poor disposal of wastewater, solid waste, and excreta. Poor disposal of healthcare waste. Healthcare waste management is a major problem in Liberia. So the behavior to shift from poor management of medical waste is a main focus of the strategy. Open defecation is a major issue, as you saw in the previous slide, where about 53% of the population still practice open defecation. And lastly, animal husbandry within family plots is a major issue. People rear animals, allowing it to graze freely in communities. Next slide. So there are drivers for behavior change that the strategy has highlighted. This is adapted from WSP 2004. But we found out that in Liberia, these drivers are similar to what is common in Liberia. And if you look at around the category of prestige, family will feel that if they were to do something that's related to improving their hygiene status, either by improving their toilet facility or their drinking water sources, that is affiliated with they identify with urban elite. So people who are elite live decent lives. So that's the prestige aspect. It expresses new experiences and lifestyle acquired outside the village. So once you start to practice drinking clean water or using improved toilet, it suggests that you have traveled to bigger cities, and that gives them prestige. So we're trying to promote these types of behaviors among the rural dwellers. Around well-being, we see that there are so many drivers in Liberia, but particularly if you look at around the protection, personal protection, especially health and safety from supernatural dangers associated with open defecation. In Liberia, people feel that if they were to use the boot or practice open defecation mainly during the night hours, they are afraid not necessarily that the environment is polluted, but that there are spirits out there that will harm them. Also, they don't really focus on dangers such as snakes or other harmful pests that may be out there for some of that drive. Although protection of family from mundane dangers, accidents, snakes also is an issue but the issue of spirit is also something that we see here, which is a supernatural danger that they perceive. Next slide. The strategy focuses on 4 major settings, and these settings are very cardinal to Liberia because this is how our population is organized. So we have people who go to healthcare facility for treatment. We have people who are home, mostly who are not doing a major job. We have people who are farmers, so if they're working, they are home. We have school-going kids or pupils, and then we have people who go to public places. So for healthcare settings, we are focused mainly on hospital or healthcare facility administrators, the officers in charge, clinicians, patients, and caregivers. For the domestic settings, we focus mainly on the parents, caregivers, the community leaders, religious and traditional leaders, young people, including students and out-of-school youth. For schools, both private and public, we are focused mainly on parent-teacher association members, school health club members, teachers, principals, and other school leadership. And for public places, mainly food establishment, hotels, and marketplaces, we are focused mainly on the food handlers themselves, including domestic workers, managers, and customers. Next slide. So there has been progress made so far since the campaign was launched in 2022 of June. We've gone 1 year, a few months down the road, and we see that there are a couple of achievements made around stakeholder coordination. Now we see that there's better coordination among stakeholders. Initially, they were non let's say engagement of stakeholders around hygiene promotion. But with the launch of the strategy and the campaign, we see that we are having frequent meetings around how we can better organize the campaign. There's also increased awareness in terms of food hygiene, menstrual hygiene, management, hand hygiene, and environmental hygiene. There's also an increase in advocacy. We see that there's now advocacy around how can we improve on access to sanitary pad among young girls. So there's this effort to reduce tax on sanitary pads so that there can be more use of the pad to improve menstrual hygiene management. Lastly, we are expanding access to market, especially when it comes to social marketing of sanitation products, sanitation marketing. There is currently an effort with the USAID support that is being implemented by one of our partners in Liberia. There is an improved toilet that is being sold using sanitation marketing approaches. And currently we have over 12,000 of those sold already. We call it the QUEE toilet, Q-U-E-E, QUEE meaning improve or civilize. So over 12,000 of those toilets have been sold in 5 of our most populous counties, that is Nimba, Lofa, Bong, Grand Bassam, and Monserrate counties. But we also are focused on expanding access to the treatment product for household water treatment and safe storage. So WaterGuard is now being sold in supermarkets, and people are able to access WaterGuard to treat their water at home. Next slide. So where are we and how can we leverage support from the subnational level? Initially, when we launched the campaign, it was focused at the national level, but we realized that there's a need to engage the subnational level colleagues, mainly the county health team. So we are now working with the county health team where they are providing leadership to roll out the campaign. The environmental health officers that are assigned in all of our 15 counties are doing a great job in terms of coordinating the implementation of water services and also the Hygiene for Health campaign. There's decentralized celebration of important days such as the World Water Day, World Toilet Day, and the Global Hand Washing Day. In 2023, we trained local leaders in 6 counties, and these are counties that are bordering. We have Côte d'Ivoire on one side and then Sierra Leone on the other side. And these are mainly partner-supported counties. One would ask, why are we targeting 6 out of 15 counties? We actually focus where partners comes in. It's not that other activities are not happening, but these counties, including Grand Cru, you may not be familiar with Liberia, but Grand Cru is one of our smallest counties, and they are hard to reach, so we prioritize the Maryland also, River G, Grand G there, and in the western side is Grand Cape Mount and that of Bapun counties. Now we see that county authorities, superintendents, city mayors are working along with the plans that were developed. There were WASH plans developed, and the plans focus mainly on how the counties will be open defecation free but also how they can improve on water services and hygiene promotion activities in general. Next slide. So why do we want to leverage, or why do we want to focus on local leaders? Local leaders are essential for hygiene promotion for several reasons. And in Liberia, we thought to share three of the biggest reasons with the audience. One is they know the terrain. The local leaders are just in the communities. They are familiar with the issues. They know the barriers. They can facilitate how people shape behaviors. And they work closely with actors that are there. They also have diverse background. You know, some of them are religious leaders, they're traditional leaders, they're political leaders. In this part of the world, people respect religious leaders a lot, and traditional leaders are highly respected, likewise political leaders. So working along with these individuals help us to communicate our hygiene, messages to the public, especially the rural dwellers. They are accountable. So accountability is a major issue in Liberia, but local leaders are respected because of their accountability that they have working with their local laws or bylaws. So these are some of the reasons why one will work with the local leaders, because they are highly influential. Next slide. So we do experience, or we have experienced a number of challenges working with local leaders, and we think that it's good to highlight. For example, if you are engaging local leaders, you have to be aware of these challenges and how we have been able to work around them. In Liberia, for example, there's primary focus on issues. Water, sanitation, hygiene has a primary focus at the national level, the county level. Now, if you go down to the district level, there are gaps, and the gaps are due to limited staffing. We don't have environmental health officers or WASH officers in all of the districts in Liberia. Now, if you go below the districts where there are clans, is the lower administrative level, you don't also have staff there. So currently, we are working along with other cadre of health professionals that are at the last mile. For example, we have community health volunteers that are out there that we can work with, and we are leveraging their support. We also use local languages. However, because of the barrier, most of those that are at the national level do not speak the local dialects. So using local vernacular becomes an issue. What are we doing to improve that? We are working with community health assistants that are out there that are familiar with the local terrain and also speak the local language. They are being used to promote hygiene. There's limited resources for hygiene. More focus is placed on water and sanitation. But what are we doing to make sure that hygiene has a bigger piece of the pie? We continue to advocate for increased focus on hygiene issues in Liberia. Next slide. So looking ahead, we think that there's hope because the hygiene campaign strategy is in the second year. But for the remaining years, we will be increasing training leaders. We started with 6 counties. We're going to increase by targeting the remaining counties. We're going to create actionable resource materials for local leaders to access, at least to be able to increase their knowledge on hygiene for health. And then we want to measure our progress based on what we have put in, the input versus the output. Okay, these are things that we think we will focus on in the coming months or years. Thank you for listening.
Great. Thank you, Amos. Next slide. So next we will hear from Lindsey Leslie, who's joining us from Breakthrough Action. At Breakthrough Action Liberia, Lindsey serves as the Social and Behavior Change Advisor, where she leads a multidisciplinary team and provides technical oversight for the design, development, implementation, and monitoring of complex integrated SBC programs. Over to you, Lindsey.
Thank you, Tyler, and thank you to everyone joining today to learn more about our efforts to support the Hygiene for Health campaign as part of Breakthrough Action Liberia. Next slide. So I'll give just a short background on Breakthrough Action Liberia. We're a USAID-funded integrated social and behavior change project. We've been in existence since 2020 in the country. And we work to implement effective, high-quality social and behavior change activities in line with 3 different objectives, which are listed on the screen. I'll just point out that for the first objective, you see a number of health areas. We work across malaria, maternal child health, family planning, reproductive health, and even with zoonotic diseases. But within our WASH work, hygiene is a focal area. And I'll also highlight that we operate in 12 of Liberia's 15 counties. So we're not in the entire country, but support the Hygiene for Health campaign. We're doing that at a national level. And then on the ground, we're in 12 counties. Next slide. So our support for the Hygiene for Health strategy to date has been primarily looking at the health areas that we support under our project. So we collaborated closely with NPHL and the Ministry of Health to promote use of safe water, including the use of the water, the treatment of the water, and storage of water. Also, hand and food hygiene have been a priority. Aspects related to environmental hygiene, such as consistent use and maintenance of latrines and hand pumps. That's also been something where we've collaborated with NPHL. And more recently, we've gotten into menstrual health and hygiene promotion. Next slide. When the strategy was being developed, we actually worked to incorporate research findings from a mixed method research that we conducted in 2021. So in 2021, we conducted research focused on water behaviors and sanitation behaviors. And some of the sanitation recommendations from that study are listed on the screen, and they're actually also included in the strategy. So from that mixed method study, we learned related to sanitation that people in Liberia are already motivated to use toilets. And so really the goal is sustained toilet use on a daily basis and the cleaning and maintenance of toilets. So that's been something that we've been trying to promote as a project. Then we also learned from findings from the study that the influence of leaders and community role models should not be undervalued. They're incredibly powerful, and they can work to support hygiene efforts, and so they should be welcomed, and you should really work for their buy-in. And so that's also been something that we've integrated into project approaches. The final point there is hand washing with soap needs to be promoted in an integrated manner with sustained toilet use programs. And so that's also something that we've kept in mind as we continued working with NPHL and Ministry of Health. Next slide. In terms of the water focus recommendations from that same mixed method study, we learned that we should design and test accountability mechanisms to empower community members. We should explore strategies to pool community resources, include community stakeholders, and support the establishment and continuation of community-based water management committees. So the overarching theme here is community is key. We need to be working in a myriad of ways with community in order for true improvements, long-lasting, sustainable improvements in water access and water maintenance. And so that's also something that we've taken forward as we've continued to support the Hygiene for Health campaign. Next slide. So the big idea here, the idea that we are excited to share today, is one of the ways that we've been supporting the Hygiene for Health campaign. This idea is allowing us to build on what already exists. As a USAID-funded project, we know that Liberia is a USAID priority country for WASH when it comes to water, sanitation, and hygiene. There are a number of partners who are working on WASH in Liberia. And so we did not want to duplicate any efforts. We wanted to build on the infrastructure that already exists and the knowledge that already exists. So we were brainstorming to understand how we could best do that. And then as we were having those discussions, we were also understanding from NPHL that there really needs to be an increased focus on the subnational influential leaders. And this dovetailed really nicely with the results from the water and the sanitation studies. So the big idea was to reach community leaders and local government entities at the county, district, and community levels across the 12 project counties where Breakthrough Action works. And it's because they're primarily responsible to advocate and generate resources to care for and maintain existing WASH investments. So if they feel it's important, it's more likely that those investments will last longer. If they feel it's important to take up certain actions, it's more likely that they'll promote it. And so the reason that we sort of went in the direction of a pilot remote training was because we were testing the idea of rolling out these inspirational testimonials and delivering them via interactive voice response technology. So actually the next presenter will talk in much more detail about IVR, or interactive voice response technology, but we chose to go with that technology because we were working across 12 counties. And these 12 counties, it could be difficult to bring everyone to a single location. And we want to be able to have multiple touch points, be able to reach people repeatedly over a sustained amount of time. And it would be difficult to do that, in person. So we brainstormed and we ultimately went with a remote training. Next slide. So some of the behaviors from the Hygiene for Health strategy that would be reflected in this remote training. The thematic areas included safe water, hand hygiene and food hygiene, consistent use of latrines and hand pumps, and routine maintenance of latrines and hand pumps. And again, we're building on what already exists. There may already be knowledge or intention or even actions that are happening at the county, district, or community levels related to these thematic areas. But these were areas that the campaign, the Hygiene for Health campaign, wanted to promote and wanted to see happening more frequently across more areas of the country. And so those are how we determine the priority behaviors for this particular intervention. Next slide. The timeline for developing and rolling out the pilot is listed on the screen. So from January to April last year, 2023, we brainstormed, conceptualized the approach, developed the concept note, developed the different role play content or the narrative content that would be used on the technology. In May, we were able to record the content and load it onto the IVR technology. And then from June to July, we spent time launching and then on a weekly basis, disseminating the modules as part of the remote training. And then from August 2023, once the remote training ended, we switched into a different gear because it was also important to us that the training resulted in applications, that there was actually action at the community level, at the facility level, at the district level in relation to what was learned during the training period. So we conducted routine follow-up with WASH stakeholders and influential leaders to monitor the application of these learnings within their communities. Next slide. So I'll also mention that it was a very collaborative process. From the very beginning, we were working with NPHIL and we were working with a particular group, the WASH Technical Working Group, which is a diverse group, multiple backgrounds, different stakeholders from different units within the ministry, but then also partners. So it was a wide range of backgrounds and experiences that contributed to this process. The way the contributions happened were jointly reviewing the content, looking at the narrative content line by line, changing the names, changing some of the language used, changing some of the sequence, trying to refine things so it's more applicable, more relevant, more realistic, and ultimately ensuring that the content focuses on the knowledge that should exist or that we want to impart. Also the attitudes that are realistic, but also what the norms we want to change and the norms we'd like to see. And also finding opportunities to incorporate leadership skills, all in support of hygiene efforts. So at the end of this process, the process continues, we're still collaborating, but at the end of the content development process, we had a total of 7 modules and they were broken into 2 types. We had 5 narrative modules and each of those narratives included 2 comprehension questions. And then we also had 2 assessment modules or like a midline and an endline that focused on assessing comprehension and encouraging additional engagement with the content. Next slide. And I'll say a little bit more about who we intended to reach through this remote training. So in the 12 counties, which are in the blue on that map on the screen, we worked with NPHIL at the national level to identify a list of all the different individuals that should receive the training because they're influential and have a direct role to play in WASH in some way. But then also to actually define the list, we sat with the county health teams in each county, and that's how we developed the list. there was some criteria that was necessary. Each trainee or prospective participant needed to have a functional phone. It doesn't matter what type of phone, as long as it could receive calls and make calls, that was sufficient. And they needed to be involved in WASH in some way, shape, or form that was influential or direct. And that was what we were working out with NPhil and the county health teams. And so we collected the following details, as you see at the bottom, from the county health team to comprise a list of between 550 and 600 participants across the country. Next slide. So I'll speak a little bit more about the content itself. We're really excited to talk about the content. This image is just us recording the content. We were doing that at a local radio station. Next slide. So we were excited to, I suppose, try out a new form of content, narrative communication. So narrative communication can be defined as any cohesive and coherent story with an identifiable beginning, middle, and end that provides information about scene, characters, conflict, or perhaps it raises unanswered questions or unresolved conflict, or perhaps it provides some sort of resolution. And so a paper from W.R. Fisher 5 says that narrative communication has several paradigms, 5 total, and I'll just pull out 2. That humans are naturally storytellers or observers of narrative, and that, in fact, we're surrounded by stories, and we use them to make sense of the world through storytelling or reporting of the sequence of events. And so there are actually ways that this has been shown to be effective for health promotion and SBC. Stories capture attention, they evoke emotion, especially if they're designed to be engaging and compelling, and that those qualities could make it effective at producing positive changes, especially in relation to perceived norms and intention. Part of why this happens is because stories create this openness to information. You want to hear the end of the story. You know that a story is starting, you know that there's a middle, you want to hear the end. But if that perhaps the same information that was being conveyed, not in story form, perhaps you would interject, perhaps you'd have an argument, perhaps you would stop the process of the communication being transferred to you because you'd have something that you need to say back. But maybe if it's in story form, perhaps you want to hear the end and you're more likely to absorb that information in a different way. Another way that stories have power are by allowing this identification with characters. You can see yourself in their shoes, perhaps even doing the behavior, perhaps even taking the same sort of steps. This process is called transportation, when you can put yourself in the shoes of the character. And in doing that, it draws on this vicarious experience. You could rehearse how you might do a situation before it even really happens to you in your life. So you might hear a story and think, oh, I would have done this. And just that quality means that you can run through what you would actually do if you were to find yourself in the same or similar situation. Another reason why we chose to have a more narrative approach is because we've seen that role play has been shown to boost the effectiveness of community leadership in achieving WASH outcomes. It facilitates social learning and actually has been shown to strengthen capacity for water management. Next slide. So in terms of how we were using or how we approach narrative communication is we actually developed first-person narratives, and they were designed to be shared by the individuals in their own words. So these, let me say, were testimonials or role plays that we developed through the technical working group. We did not have individuals from the community come and give a first-person narrative, but we tried to emulate that. That's when we were designing the scripts or writing the scripts, we were writing it as if it was someone sharing their own story from their own experience, being an influential leader and improving WASH in their community. And so we tried to make it engaging in that way, which having that first person approach can address some of the limitations of traditional didactic learning. I'm not telling you to do this, I'm telling you I did this, and you still have choice. You still could choose to do something different, but you might use my narrative to educate yourself. Maybe my narrative could be motivating to you, or maybe because you see that I've done it, maybe that would help reduce your fears of getting started to do the same thing. As we were approaching and designing the scripts, writing the scripts, we were considering different contextual elements. So we thought about, what are the norms? Who's typically involved in this particular area of WASH that we'd like to promote? Who typically leads this behavior? How often does it need to happen? And what are the complexities in doing this? Who would have more influence over like whether this happens or not? What are the literacy levels? What is the current mindset towards this particular behavior? So we had a number of areas, contextual elements that we were considering as we were reviewing the scripts and revising the scripts. And ultimately, when we had the final scripts, making them available to all of these influential leaders across the country via interactive voice response, that made the story more accessible. You could have it at the touch of a button, and you could choose when you would listen, or it was available to you. You could actually hear someone's voice in your ear, and that helps to emphasize that first person storytelling approach that we chose to use. And each package included a unique lesson. So as you're listening to these narratives, you have simulated actions, you have different strategies you might be hearing, and then each module, each package ended with a positive resolution and a clear call to action. Next slide.
Just giving a 1 minute warning, 1 minute warning.
So the overall outline for the modules is listed on the screen. As I said before, we had 7, 5 that were more narrative. And so you see the topic and the communication objective on the screen. And then we had 2 that were focused on assessment. Next slide. This is just an overview of the format for each individual narrative module. We tried to keep it, between 3 and 5 minutes. Ultimately, some went a little bit over that, but in general, 3 to 5 minutes is what we were aiming for, with the majority of that time being on that recorded role play, that narrative portion. Next slide. This is just another image that conveys that we had these 5 modules, and we're trying for 4 minutes of content, including the call to action and the knowledge retention questions. We went over. The thing I'll highlight here is if somehow, because the way the remote training was designed is you would receive a call, but somehow if you missed that call, you would be able to call in and be able to access the content or take the midline or the post test. Next slide. So this is just a sample of the very first module that someone would have received. And you'll hear that it's a little bit more instructive on how to use the system and a little bit more preparatory for what's coming up in terms of the remote training. Go ahead, Tyler.
Hello there. My name is Sis Grace, and I'm here to give you lessons on improving hygiene in our communities. These lessons are part of the Hygiene for Health campaign. I will give you lessons for 7 good weeks. You will be receiving 1 call per week. Each call will last for 4 minutes. Please listen carefully to the entire call. If you miss the call at any time, you can beep the number to receive the call for free. This will be at no additional cost to you. All voice messages will start with "Our Health, Our Life." Remember, this is a recorded call. I'm not a live person. At the end of each call, you will answer a quiz. Respond to each quiz by pressing the numbers on your phone's keypad. The quiz only seeks to assess your understanding of the weekly messages. You can put your phone on loudspeaker when receiving this call. When you have finished listening to this first call, please save the contact number as Hygiene for Health so that you can know that it is us that is calling you in the future. Remember, this is an important message from the National Hygiene for Health campaign team led by the National Public Health Institute of Liberia and Phil. These lessons will reinforce how you support water, sanitation, and hygiene business in our communities across the country.
Okay, and we'll hear just one more on the next slide. And this is more of the story format. Go ahead.
Today, let's hear from Pa Emmanuel. He is a town chief. He is very, very proud of how his community takes care of their latrines and hand pumps. He always tells his people to keep them clean and in use. Pa Emmanuel, welcome.
As the town chief in my community, I am responsible for the whole town. I have to take care of the people, but also the buildings, the animals, and all the things in my town. Since it is my responsibility to protect the people, I always tell my community that the latrine must be used and must be clean so that we can live a healthy life. We have a schedule to make sure that the latrine is always clean. I also tell them to use their hand pump, and they should also treat it with water guard to drink clean and save water. I also tell my people to clean our environment and make sure we separate the plastic from the other dirt and then take it to a safe dump site. Since we have started doing this, we have seen less sickness. When sicknesses like running stomach is low and the latrines and hand pumps are shining and the community is clean, I feel I'm doing a good job.
Next slide. So after the training was, all modules were sent out, we conducted some routine follow-up, which I'll quickly talk about. Next slide. So as I mentioned, the remote training ended in August. So when we visited Grand Bassa County, which is one of the counties that received the training, and we talked to stakeholders there, we learned that there were a variety of ways in which they were starting to apply lessons from the training. They were starting to share those messages with their community or conduct their own training sessions with people responsible for hand pump maintenance, or even taking opportunities like after the repair of damaged hand pumps to talk about the continued maintenance of hand pumps. Next slide. And even later on, when the previous slide. The previous slide from Maryland County. Thank you. Even later, when we discussed with leaders from Maryland County, we learned that they were organizing cleanup campaigns. They were reintroducing cash cost systems to raise funds for broken hand pumps. And all this was very encouraging because this is 3 or 4 months after the end of the remote training. Now we can go to the next slide. So we learned several lessons. We learned that we should reduce the time of each module to really maintain caller engagement, that we could consider using local languages to increase comprehension because we're working with people at the community level, like women leaders and town chiefs, and that may have increased their comprehension. That we also could have solicited input from the influential leaders of different WASH stakeholders before developing the content for even more relevance. Last slide. We also have explored pairing the remote training with continued in-person follow-up through like listener groups. And those listener groups could help with learning from one leader to the next, and also having small informal sessions that promote opportunities like how they're applying the lessons. And so that's where I'll end. Thank you so much for listening. Back over to you, Tyler.
Great, thank you, Lindsey. And last but not least, Dr. Nii Lante Hayward-Mills joins us from Viamo, where he serves as the country director of Liberia and Ghana. Nii has extensive experience working with the health services and ministries of health in Ghana and Nigeria, and has a background in public health promotion. Welcome, Nii.
Hello, everyone. Glad to be part of this session. Next slide. And the next slide. Next slide. Right. So Viamo stands for Via Mobile. Essentially, what we do is connect individuals and organizations using digital technology for people and their beneficiaries to make better decisions. Interestingly, Viamo is part of the Breakthrough Action Consortium, and together in Mali, Guinea, Senegal, Zambia, DRC, Nigeria, and now Liberia, we support the Breakthrough Action Project with digital solutions. This being just one of the many that we are supporting with. Next slide. All right, so this is just a map of the countries that Viamo operates in and the telcos that we work primarily through the telco. So regardless of your mobile phone network, Viamo Breakthrough Action be able to reach you and also collect feedback from you. Most importantly, on any device, you on any type of device and in your local language. So next slide. All right, so I am here primarily to talk about the technology. So I'll go quickly so that we can ask questions about the major presentation from Lindsey and Amos. So really, why mobile? Why did we use mobile phones? If you look at the demographic and health survey, you're looking at computers about 8% in Liberia. You're looking at radio coverage about 40%, and you're looking at mobile phones over 60%. Meaning it's one of the many channels that you can use to reach your end users, your beneficiaries, your stakeholders. So you're looking at quick and real time. It's cost effective. It's interactive, meaning you can collect data for them back, push data, collect feedback. It's targeted, right? We targeted watch community leaders, and it's measurable. You're getting your feedback in real time. Real time as in the next minute after you send it. You don't need any new device. You don't need a tablet. You don't need an internet-enabled phone. The training is in local languages, making it more understandable. We were able to do this across multiple countries at the same time, rather than bring learners together, which could have been a very massive logistical constraint. Also, during the rainy season, for instance, you wouldn't have to go around bringing people together. And even in times of conflict, you're able to, or a pandemic, you're able to reach people more seamlessly. We also have quizzes to test knowledge, attitude, and practices, and most importantly, reinforce key concepts, right? So in the event they got the question wrong, they were told what the right answer was. The training fits into a learner schedule. So opposed to, say, a workshop where you'd have to schedule 9 to, say, 4 p.m. With this training, learners could take it before work, over the weekend, after work, during their lunch break. So pretty much suits when they are available to do it. And compared to face-to-face, the costs are relatively small. And I'm not saying this to denigrate face-to-face. It's part of a blended approach, and also one of the ways that we can reach our target audience. Next slide. Okay, next slide. So what did we learn? Collaboration is key. Also sensitization. We made sure that we sensitized everybody that was involved to expect the call and to be ready for it. We conducted a soft launch. So this is where we found out any kinks in the sort of implementation, where some people were not receiving calls or the quizzes were not how they were meant to be. We also was very user-centered. So we asked participants what the best time was to collect their call. We also ensured there was buy-in from the county health teams, and also from their supervisors and anybody that was involved. And finally, we had the perfect we asked them when and how often to send, and that was about one call a week, give or take. Next slide. All right, so I'll go into the results. Next slide. Sort of feedback we got from this training. So of the 263 persons that answered the first quiz, we know that 209 of them finished, and there were no incentives, 0 incentives. That's 80% of those who started the quiz finished the quiz. So clearly there was something about it that made it compelling and interesting enough for these leaders to keep coming back. Next slide. So this slide shows sort of the baseline and the end line question. So we filled out a baseline to them before we started and an end line. And you can see clearly that most of them started in around the 70th percentile. but at the end of the training, they were around 90th percentile. So there's demonstrable learning from before exposure to after exposure. Next slide. And this is one of the benefits of using this. You're able to actually measure learning. In terms of feedback, 90% of the learners, the leaders, mentioned that the information was very useful to them. So we have also feedback from our beneficiaries. Next slide. Right. And most importantly for me, did they apply this in real life? Right. So during some of the follow-up visits in Magibi, the district health officer for Mambakamba, Wataseli, shared some of the examples. And since the training, she's been reinforcing proper waste management practices. She's been monitoring hand washing practices and proper labeling of the management of waste. And finally, she's developed plans to extend these changes to other health facilities. So this is sort of the gold measure for us at Viamo, actual behavior change, not just learning. Next slide. Next slide. Okay, so to wrap up, we've documented all the learnings and all the success stories from this to inform follow-up project. We can confirm that IVR in the Liberian context is very efficient, especially for large, dispersed, and relatively difficult to reach populations in terms of the demography, the rates, and how difficult it is to traverse the country. We know from the data we've improved local leaders' knowledge and application. And then, as I mentioned earlier, we understand the Liberian context in terms of connectivity, in terms of behavior, in terms of phone ownership, and generally in terms of risks and bottlenecks that may exist. Finally, there's a strong recommendation from all of us who implemented this to do a bit more of these and also use it in a more blended approach where it becomes sort of an add-on to face-to-face meetings and to measure knowledge, attitude, and practices. Next slide. I think that's it. Thank you so much, and we'll take questions from here. So over to you, Tyler.
Great. Thank you, Nii. And thank you to all of our presenters. Now I will ask the presenters to come on video as they're able, and we'll begin our question and answer session. So for those in the audience, feel free to keep adding any questions you might have to the Q&A box on the bottom of your screen. We have one question there right now, wondering about the foundation that you're building on. Actually curious if the participant might be able to come off or raise their hand. We're not quite sure how you mean when you say the foundation, if that's the IVR technology or if it's something else you're referring to. If you might be able to raise your hand or clarify within the Q&A box. And as you do that, we could start with another question, just a sort of general question. I was curious about how was this experience with audience members using the IVR system? Were there any challenges with that or any ways in which you had to pivot as the campaign went on? I'll open that to anyone that was involved within the campaign.
Nii, would you like to speak to that from the technology side?
So the technology is also as strong as the network coverage. So we realized that we had a few participants who were out of coverage area. So what we recommended was two things: for them to give us a backup number, right? So that we had two numbers. Alternatively, we recommended that for those, but those were outliers for the most part. For those who did not have network coverage, they would, in the event that they went into town or went to work, they would access the training from that point. Also, initially, it's the first time, so it's a bit different, right? So the initial acceptance was a bit, it takes a bit of a while to get used to putting your phone on loudspeaker and pressing the key parts. But once you're done with model one, it's pretty straightforward. Over.
I'll mention two things. So we actually had to launch twice. We had done like a series of preparatory steps, sending out text messages, letting people know that this would happen, but like Nii said, it was a little bit of a process and a learning curve. And so we tweaked a few things, and then we launched a second time and got way more traction that second time after changing when the modules went out or when the calls went out, changing the timing, the frequency of them, and then also having those reminders on the second and fifth day. And then the second thing I'll mention is, I think I had said that there are two types of modules that we sent out. There were the narrative modules and then those assessment modules. And so everyone was used to module 1, module 2, module 3, the narrative content. So by the time that they were familiar with that, module 4 was a different kind of module. Confused. They were expecting to pick up and listen to a story, and instead they were asked to respond. And that also was a little bit of confusion, but good thing that our team and you know, those that are more familiar with or able to navigate it, were able to help provide support where possible. Thanks.
Great, thank you. And since we're talking about the platform, just curious if the participant was wondering about the effectiveness of the IVR platform. Have you found that the IVR platform is an effective use to reach people with these messages, or are there any ways to improve the platform or the usage of this platform? Open that to anyone.
Yeah, I'm happy to take that. So there are two ways in which we sort of measured behavior change or effectiveness. So one is through these quantitative questions, right, where we do a baseline and end line, right? So you're able to measure change in learning. You're able to measure proxies for behavior change, right? So that's one way. And as I mentioned, participants started at around 65% percentile. And by the time we're done, they were at the 90th percentile. So there's clear change in knowledge there. That's one. Two, I think there were also qualitative measures, right? Of observations and testimonials. And we know that in terms of that behavior, some of the learners were actually rolling out plans and doing things differently, and they reported change in behavior. There were some observations as well, and I'm sure Lindsey can speak to that. Lindsey.
Well, I actually just going to answer the question by saying, you know, there was obviously opportunity for additional monitoring, additional evaluation. We had 600 people who had signed up, but ultimately we see that 263 people were really engaged with the system. And so there are additional questions that we could ask as to why, what could we have done differently for those other, you know, 300 plus people. And then we continue to hear stories about some of the change, but it's difficult to know if that's just because of the IVR effort or if that's because of some other effort. And so those are some questions that I think we could continue to ask before we say it's the most effective. But obviously it worked well enough, and we see that there's a lot of evidence of change that people themselves are linking to the lessons.
Yeah, I just wanted to share some experience. I happen to listen to most of the modules, and I think that it's because it's quite user friendly, if I may say. So the fact that Nii mentioned that if you look at the mobile phone penetration rate, is high, it's above 50%. That's a good platform. So having such a means for people to really have hygiene promotion messages. I think it's the first time we've used this in Liberia, and the results show that at least there was a good number of people who accessed it, although people who started the module did not all of them completed, but there are several reasons why that may be the case, you know, because when I listen to it, I see that sometimes, you know, I get caught up in the middle of either my job or I'm driving, because the time period was also a factor to some of the module. 45 let's say 45 seconds. 45 seconds, yeah, may seem to be short, but if you have a day's job that you have schedules coming up, that could be one of the reasons why there were interruptions. So if we could further look at the analysis in terms of the timing. Fortunately, we don't know what time they were picking up these modules, these answers. I think most of the people who may have done that in the evening hours were those who were able to complete the modules or the questions. Yeah.
Great, thank you. And noting that we are a little over time, perhaps just a final question for folks that want to hear more about this. Are there ways to hear the modules, or are they publicly available?
Not yet. We're working on that. But yeah, not yet. But if you'd like to learn more about the approach, we did put out two pieces on the Breakthrough Action and Research website. So a technical brief that goes a little bit more into detail of what we discussed today. And then there's also a blog that was published last Friday, I think on World Water Day, that talks a little bit about the human side of this work too. So I'm not sure how we can share those. Maybe Marcella, you could come in and let us know how we could share those too, for those who want more information.
Great. I think we can share those with the recording. That would be great for everyone that attended. So we are over time. So we want to thank a big thank you again to all of the presenters. And of course, a thank you to everyone who joined us today. Today's session was recorded and will be sent out within the next day or two. Please fill out the poll that should be appearing on your screen right now. It should take less than 1 minute. And of course, please join us for future Breakthrough Action Liberia events and webinars. And if you're on Facebook, please follow the Breakthrough Action Liberia page for updates about the project and its activities. Thanks again, and we look forward to seeing you soon. All right, thank you, everyone.